हेलो। हेलो।
स्विच करो। हेलो। यस
हेलो।
डॉक्टर।
यस, एम आई ऑडिबल देयर?
यस यस यस, 1 मिनट सर।
ये कनेक्ट करना लैपटॉप।
सर।
हेलो। हाँ
हेलो
अमित,
सर, गुड आफ्टरनून।
गुड आफ्टरनून। यस अमित, आर यू
जी
गेटिंग
सर।
सम पिक्चर ऑन द
यस सर।
स्क्रीन?
यस सर, सीन।
So this is the first case, as we have seen as one of the endotype today, is a young child, 12-year-old child with unilateral allergic fungal rhinosinusitis.
यस सर।
Classical young male unilateral disease. As I told you, this is classically seen in young patient as unilateral disease most often, though we
यस
have a
सर।
case of bilateral AFRS also. And male patient, immunocompetent patient, and see the kind of disease with heterogeneous densities. Heterogeneous densities signifying the fungus and the mucin both together.
यस सर।
And the sinuses are expanding. See the expansile erosion of the lamina papricia, expansile erosion of the maxillary sinus. See the expansile
यस सर। ऑलमोस्ट
erosion.
गोइंग टू द ऑपोजिट साइड।
Yes, ballooning the septum to the opposite side.
साइड।
So this is pressure erosion of the structures around.
यस सर।
And this is the lamina papricia. In these cases, this is non-invasive. This is pressure expansion. And see how the orbit is compressed to give a proptosis in this patient.
यस सर।
Though the periorbita is always intact, this is not invasive fungus. And see, all the septations are partly destroyed. You cannot differentiate which septation is what.
यस सर।
If I come from the most anterior to see the anatomy, see this. This is frontal sinus on the left side,
सर।
unilateral frontal sinusitis. This is the orbital roof, and see, this is the frontal recess. This is frontal sinus, this is frontal recess through which it is communicating.
यस सर।
With such massive disease, it is already widening the drainage pathway. So that makes your life easier. That always makes your life easier in such massive diseases. And see the fungal material.
ओ
See, I
यस।
am changing
या।
to the bone window to soft tissue window setting. Look at
यस।
the beauty of dynamic imaging. This is bone window to see the bone erosions. Can you see very clear bones
यस सर। यस सर।
all around? And see how this bone is destroyed here. But no soft tissue differentiation is seen. Now, if I change to soft tissue window, look at this.
यस सर।
See the intraorbital structure, see the heterogeneous densities of the fungus.
यस सर।
This is classically seen on soft tissue windows. This is all fungal material. This is maxillary sinus. So this disease is unilateral, involving the frontal sinus, widening of the frontal drainage pathway, dehiscence of the lamina papricia, all ethmoidal ballooning, complete ballooning of the ethmoidal. See the cribiform plate is thinned out. Now going behind. Now the level of the postethmoid on the opposite side. See the skull base is flattened.
यस सर।
The moment skull base is flattened, it is beginning of the postethmoid. If I go back, see this is cribiform plate.
यस सर।
As I go behind, this is beginning of the postethmoid.
ओस्टियोटोमाइट्स।
Just before the beginning of the postethmoid, at this level, see the beaking of the orbit on the opposite side.
यस सर।
That is the where the anterethmoidal artery leaves the orbit. And see the confluence of these two muscles. This is superior oblique, this is medial rectus.
मीडिया रेक्टस।
And at this level, what you see is this see this recess,
यस सर।
supraorbital cell.
यस सर।
This is above the orbit. Not very big. We have case with a huge supraorbital cell as well. And as we go behind, this is posterior going behind. Now the beginning of the sphenoid sinus. See the
Sphenoid.
sphenoid sinus?
Yes, sir.
Fully expanded. See the
Yes,
intersinus septum deviate to the opposite side.
sir.
Fully expanded. And here is some descent in the bone, micro descenses for which this patient has a, some sort of vision loss started,
Oh,
for which the itraconazole and steroids he has been on last 2 days, which to reduce the inflammation and the bulk of the disease. So this is pure allergic fungal rhinosinusitis, classical presentation of allergic fungal sinusitis, unilateral disease to begin with our day.
sir.
Anything more to be shown on TT here, or do we go ahead with the case?
Sir, we'll go ahead with the surgery. In between, we can have questions from the audience here.
Yes. Anybody has any questions regarding morning discussion also, please feel free to interrupt. Or anything, any query in mind or any suggestion, please.
Yes, sir.
दूसरा अंडर कर देना, दूसरा अंडर कर देना. What? अच्छा.
Sir, audience want to see the axial and sagittal cuts of the same patient.
Yes. Okay. Just a moment. I forgot to reconstruct. Yes. See this reconstruction? Now let me take first to the frontal sinus in the sagittal plane. See this?
Yes, sir.
Frontal sinus in the sagittal plane. And see, the disease itself has widened the frontal pathway. Can you
Yes.
see?
Yes, sir.
That's what I said, because all septations have been destroyed by the disease itself to make our life easier. Massive the disease, more extensive the disease, easier it is. Only thing is, it may distort the anatomy for which you have to be careful. Now, this is your beak. The beak is here. See the beak
Yes,
in
sir.
all planes. See the beak in all planes.
Yes, sir.
Now, see, I am showing from the sagittal side. This I will show you intraoperatively as well. I am going from anterior to posterior. Look at the sagittal. I am going from anterior to posterior. And see in the coronal. As long as the beak is intact, see this?
Yes, sir.
What you are seeing above is the frontal sinus. Can you see here above?
Yes, sir.
And see on the coronal, this is frontal sinus. Now, I am going behind. See this?
Yes, sir.
Now the beak is ending. See this?
Yes, sir.
This is the frontal drainage. Can you see?
Yeah.
So from anterior to posterior, when you come, as the beak ends in the frontal drainage. What a great anatomy it is. Beak is almost always present. Endoscopically also, I will show you the best way, simplest way to enter into the frontal sinus in any given most difficult condition. For anybody, any time lost in frontal sinus identification, just refer to one structure, that is beak.
Beak.
See this, I will show you again. Unistry endoscopically, this is your beak. See this?
Yes, sir.
Follow the beak, follow the beak, follow the beak, follow the beak, where the beak ends, the frontal begins. See this?
Yes, sir.
Same thing I will show intraoperatively as well. And since this beak is the most anterior part, see here, there is no critical structure here around.
Yes, sir.
Stay laterally close to the orbit and anteriorly along the beak. As the beak ends, the frontal sinus starts.
Starts.
Whatsoever may be the anatomical, difference, beak is always fixed. See the beauty of sagittal section to understand this fact.
Yes, sir.
See again where the beak and the frontal sinus starts.
Starts.
And then the skull base is far behind. See this?
Yes, sir.
So when, like what I say always, when I work on the beak, suppose I am working at the level of the beak. From here, the beak level, the skull base is more than a centimeter away.
Yes,
Can
sir.
you see?
Yes, sir.
This is the frontal ostium level. See the frontal ostium level?
Yes, sir.
And now if I measure with my tool here, see this. If I measure the distance here, see this?
Yes, sir. More than a
From the beak to the skull base behind, more than a centimeter.
more than a centimeter. Yes, sir.
So when I come anteriorly from here to the beak, where the beak ends, where the frontal sinus starts, the skull base is more than a centimeter behind. Can you see?
Yes, sir. Yes, sir.
So you are far, far off from the skull base this way. So this is the safest way to enter into the sinuses, frontal sinus.
Sir.
Anything you want to see?
No, sir. They want surgery now.
There are certain structures which are best seen on sagittal section.
Yes, sir.
One is this configuration of the frontal sinus. Another is this configuration of the skull base. See the slope of the skull base.
Yes, sir.
Third is sphenoid sinus sella relationship. See this sella
Yes, sir.
and the sphenoid sinus. So these are the things which are seen best on sagittal section.
Title section.
Now let me show you axial section. There are certain structures which are seen best on axial section.
Example.
For example, the details of the orbit. See this orbital structures, intraorbital structures.
Yes, sir.
See the entire length of the orbit from anterior to posterior is best seen on axial.
Axial cut.
This is optic nerve. This is your medial rectus, lateral rectus.
Sir.
And see how this is optic nerve. This is the compression by the disease. See how it has pushed. Can you see?
Yes. Yeah, very clearly seen.
See this, how this has pushed the medial rectus.
Sir.
This is thinned out the lamina papracia. See, for every anatomy, for every different region, this three-dimensional CT is so important that certain sections show better details of certain areas. So for orbital details, this is best. For septum details, see nasal septum details,
Yes, sir.
axial is best. Can you see?
Yes, sir.
So for every different anatomy, every different section is better. So let's start in a couple of minutes with the surgical part.
Yes,
Okay?
sir. Yes, sir.
Please keep pouring your questions. Anybody has any suggestions or any doubts regarding the morning discussion?
खाने के बाद होगा खाने के बाद होता है तो इंटरनेशनल कोर्सेज होते हैं जैसे मैं लीडरशिप में हूँ ना टॉपिक जो लीडरशिप पहले वो
पूरा चेंज करा अनुपम ड्राफ्ट कंटिन्यू करा ये जो दोनों केस है ना, इनको साइड में खिंचवा दे। इसमें 2 सीटी थे, इसमें 2 सीटी थे, उनको दिखाए थे, उनको करवा दे। हाँ
मेन की झपकी पूरी लेंगे जब तक सर्जरी होती है। क्या है ना, वही तो मैं कह रहा पूछ लोगों को बोल दो कि क्वेश्चन पूछे।
हेलो,
Yes, sir.
यस, सो can you change to endoscopic picture, please?
Yes, sir. Now endoscopic picture, sir.
Are you getting the endoscopic picture?
Yes, sir. Sir, what is the pre-op preparation you have done for this patient?
Yeah. So what we have done, we have given a pre-operative course of since last 2 days only.
Sir.
For this, because of the impending vision issues, we have started prednisolone 1 milligram per kg and itraconazole.
I don't know, sir.
Because of impending complication and buying time and at the same time reducing the inflammation as well. See the fungal material,
Yes, sir.
fungal mucin. See this?
Yes, sir.
This is unprepared nose.
Yeah.
The second case will take has a huge frontobular cell going in the frontal sinus, maybe requiring draft 2.
After.
Third case will take is a orbital transposition. Okay?
Yes, sir.
I hope the picture is good there.
Yes, sir. It's very clear.
Okay. So this is a primary picture without preparation.
Yes, sir.
Now, as we discuss why preparation is needed to improve the surgical condition, to reduce the inflammation in the decongest the vessels, to reduce the inflammation, to reduce the vasodilatation. All these things are done pre-operatively by means of minimizing the inflammation.
Yes, sir. And sir,
Number
what is the
two is-
solution you are using now?
Yeah, this is adrenaline soaked marrow cell sponges.
Sponges.
We use 2 marrow cells cut into 7-8 different size pieces and use topically. See this?
Yes, sir.
I am applying this adrenaline on the surface, not giving any pressure at all. This is not for the pressure.
Yes, sir.
And see the single application of the adrenaline, how
It
it
has
decongest the nose.
It has improved.
See how it opens up.
Yes,
So,
sir.
role of preparation, topical preparation, number 1 is to decongest the surface capillaries. Number 2, see the parameters. Anesthesia parameters I show you.
Yes, sir.
Can you see the heart rate? It has come to 69.
69.
We keep around 60. That is the most important parameter. Most important parameter is to reduce the cardiac output by reducing the heart rate.
Exactly, sir. And at many places they talk about the hypotensive anesthesia. More than hypotensive anesthesia
We
is
are
the
not
heart
giving-
rate.
Yeah, we are not giving hypertensive anesthesia anymore for sinus surgery
Yes, sir.
because here the bleeding is capillary, which is best controlled by reducing cardiac output. See the normal blood pressure.
Yes, sir.
So no hypotensive anesthesia, only reducing the cardiac output.
Cardiac output.
See this topical preparation, decongesting the mucosa, decongesting the surface capillaries. That's the only goal.
Yes, sir.
Third is facilitate the venous drainage by keeping the head end up by 10 to 15 degrees. We call it reverse Trendelenburg position. So that facilitates the venous drainage from the head, prevents the venous congestion. All these maneuvers are important to improve the surgical field.
Surgical field.
See the massive polyposis.
Yes, sir.
The landmark identification is difficult.
Yes, sir.
Another way of improving the surgical field all the time is simultaneous saline irrigation.
Saline irrigation. Yes, sir.
Now see, I'm trying to visualize some landmark. See, this is the level of the axilla. Can you see?
Yes, sir.
And medially is the middle turbinate.
Yes, sir.
Because of the massive disease, it is compressed.
Yes, sir.
And laterally here, it looks like the uncinate process which is everted.
Yes, sir. Yeah.
See uncinate?
Yes, sir.
Attached to the lateral wall, it is everted. Because of the massive disease. So trying to see maximum landmarks.
Yes, yes.
हेलो क्या हाल है बढ़िया बढ़िया ऑल गुड this topical preparation should be given at least 5 to 10 minutes.
Sir, now actually, audience want to see that proptosis. Can it be make out like after dripping up now?
Want to see what?
Proptosis, proptosis. Yeah.
See that?
Yes, sir.
We never cover the eyes. And
Yes.
it should never be.
Yes, sir.
Eyes should never be covered. Rather, ask your scrub nurse to keep an eye on the patient's eye all the time
All the time. Correct, sir.
to see any undue movements with instrumentation inside the nose.
Yes, sir.
Never cover the eye. So now this is the initial preparation.
Yes, sir.
What I am doing now, see under vision, debriding this polyp coming out of the middle meatus.
Yes.
Yes, AFRS. See the part of the uncinate bone here,
Yes, sir.
part of the uncinate bone.
Yes, sir. Can see the vertical part of it. This is, yeah. So, sir, you will be sending some tissue for biopsy?
Yes, yes. Always. You can take tissue. Best is to acquire from the ethmoids.
Ethmoids. Correct, sir.
Best is to collect a polyp. If not, then a good representative sample of mucosa,
Because,
disease mucosa.
Sir.
So the first part is little bit debridement of the polyp and opening of the
meatus. Infundibulum.
middle meatus here.
Yes, sir.
Remnant of the uncinate.
Yes, sir.
Everything distorted. So be
Yep.
careful. Extensive polyposis and fungal disease, particularly when disease goes beyond the confines,
True, sir.
the surrounding get distorted and you have to be ultra careful to prevent complications. See, this is the inferior turbinate.
Yes, sir.
That is the uncinate process.
Yes, sir.
Use a reverse biting. See, the things are distorted here.
Yes, sir.
See, reverse biting, reverse biting, reverse biting towards the nasolacrimal duct.
Yes, sir.
Every time you feel, if you come across the hard bone, you need to stop
Yes, sir.
to prevent biting through the,
NLD.
yeah. See, that is the uncinate process.
Yes, sir.
Full distortion. So be careful. That's the maxillary sinus on this side.
Yes, sir.
Most important goal in this surgery, as we discussed yesterday, fungus is an antigen,
Yes, sir.
and we have to remove the fungus thoroughly.
Yes, sir.
We have to give the wide openings, as this requires a long-term surveillance.
Yes, sir.
This is IgE driven mechanism. These patients are allergic. This is pure IgE mediated disease.
Yes, sir.
Out of other variants of eosinophilic sinusitis, this and CCAD have the least chance of asthma.
Yes, sir.
They have least chance of lower airway disease asthma,
Yes, sir.
unlike other eosinophilic sinusitis. And since this is IgE mediated, in case the biologics are considered in any given situation,
Yes, sir.
lot of trials are going on with the omalizumab, because omalizumab is anti-IgE monoclonal antibody.
Yes, sir.
This is the right candidate in case any time monoclonal antibody to be used. Right candidate for
Audio vision. आवाज.
though omalizumab is not approved by FDA
FDA yet. Yes, sir.
for any sinusitis.
Yeah.
See the fungal mucus.
Yes, sir.
Hydro रखना hydro.
So, sir, will you be using the hydro dissector here, the hydro debrider which you have?
Yeah, I will.
Sir.
I'm using suction first to remove.
Yes, sir. Debris.
Yeah. This is 0 degree only.
Yes, sir.
Only 0 degree so far.
Yes, sir.
बता दे। यही चल रहा है क्या? उड़ गया? हेलो,
Yes, sir.
See, this is the maxillary sinus.
Yes, sir.
Now I am working with 0 degree.
Yes, sir.
Now, one of the most important landmark at this point of time, I show is the upper part of the uncinate process.
Yes, sir.
Upper part of the uncinate process is the structure which is closest to the orbit. Closest
Yes.
structure to the orbit.
Orbit, correct, sir.
Though here everything is distorted and since the orbit is dehiscent at places,
Sir.
see, this is upper part of the uncinate. See this?
Yes, sir.
Best way is go behind it, see this?
And bring it out.
And fracture it anteriorly.
Yes, sir.
And the moment you remove, you will find the lamina papracia, your lateral wall of the entire sinonasal corridor.
Yes, sir. खुल गया ना ऊपर फ्रंटल दिख रहा है
Fungal material everywhere.
yes sir
Still only. Zero degree only. Now,
Sir.
before going up, you cannot see anything beyond this with a 0 degree.
degree will take 70 degree
Yeah, 70 degree is the key for many regions. It helps you looking into the corners under vision.
yes sir
See this mucin.
yes sir
See this thick mucin not coming even in the suction. And if we leave this mucin, our pathology will go on like this.
yes sir
It is going to come back in the same fashion. So here I will use the hydrodebrider to show you how effectively it can be cleared in no time.
yes sir
Law, hydrodebrider. Keep optimizing your field. 73. Keep optimizing your field with the marrow cell. We have changed to 70 degree now to show you something. See the interior of the maxillary sinus?
yes sir
चलेगा Give me 70 degree, all this mucin. All this mucin along the lamina. See this?
yes sir yeah
Let's put the lamina.
yes sir
Now see, this is hydrodebrider nozzle
yes sir
with a 70 degree. Now I am turning it inside the maxillary. See this?
yes sir oh nicely yeah
I can rotate 360 degree without any problem. See this?
yes sir so this is for the audience last year DNB they had asked for about the hydrodebrider now you can see they had put up a picture and asked for the so this is the hydrodebrider yes sir last time DNB they had asked actually
Or under all section. Yeah. There is a strong water jet,
sir
very strong water jet to dislodge any material as existing on the mucosal surface.
yeah.
Let's have a view. See inside.
Sir. So, sir, there is some curiosity about the hydrodebrider. They want to see from the external camera how does it look like, and one member want to know the price of hydrodebrider.
Price is, I don't know, when I bought it was not much years back. But I
Sir,
don't know, maybe 6-7 lakhs something.
but it's a good investment.
Yeah, but mostly I use this only in allergic fungal rhinitis.
Yes, sir.
So that
Yes, sir.
you have to clear it. Go there. Now, still you can leave the fungal spores
Sir.
within the folds of the mucosa.
Yes, sir.
So what you need to do is decongest the mucosa.
Packet.
Yes, decongest the mucosa. See this?
Yes, sir.
To open up the mucosal folds. So
Sir.
that will tell you if any fungus is still there. See this?
Yes, it came out. Yeah.
So in the swollen mucosal folds, still one can miss.
Sir.
You have to decongest the mucosa. See this?
Yes, sir.
On any slightest of the doubt of disease removal in maxillary sinus, particularly in AFRS.
AFRS.
In other polypoidal mucosa, you can leave. But in AFRS, you cannot because you may leave the fungus in between.
Yes, sir.
See this?
Yes, sir. Now it looks better.
Better, but I will show you one of the techniques. One of the techniques to go freely in the maxillary sinus everywhere under vision. See, that is canine fossa.
Yes, sir.
Yes. No, correct. See, at the mid pupillary level,
Yes, sir. Yeah.
at the mid pupillary level, see this?
Yes, sir.
1 centimeter above gingivobuccal sulcus. See this?
Yes, sir. Yes, sir.
This is the thinnest region of the maxillary sinus. See, I am in. Hello?
Yes, sir. Yes, sir. It's seen, sir.
Okay, here. Can you see my trocar there?
Yes, sir. Now it's seen. Yes, sir.
What I will do now, I have to clear the maxillary sinus thoroughly
Yes, sir.
because even I live the smallest of the fungal material, I am in trouble.
Yes,
See
sir.
this now?
Yes, sir.
I push my red 40, remove the trocar and cannula both.
Yes, sir.
See this?
Yes, sir.
See, settling down the entire mucosa. Can
Yes,
you
sir.
see?
Yes, sir.
I don't want to leave any mucosal fold and out because in AFRS, if you leave behind, see now everything clear?
Yes, sir. Yes, sir.
So now this is much confident, much better. We'll leave a marrow cell for a while and clean it up and wash. This in the maxillary sinus. This is very important in AFRS because you don't want to leave any fungal material. Look at the maxillary sinus now.
Yes, sir.
Hello.
Yes, sir. It's looking much better than what it was.
Yeah. So we will
What is
again rinse with the hydrodebrider.
it normal or and what is the 0 degree endoscope Tibetan plate or
No, that was the 40-degree rad.
40 degree?
40-degree.
Again rinse with the hydrodebrider to ensure that no
Same Taka cannula is used.
That's for
nothing is left.
Yeah. And he used a 40 troca, the same 40
See
rad.
this?
Yes, sir.
360 degree. I am just pouring on the anterior wall. See the state of mucosa now.
Yes, sir.
There is no question of leaving behind anything. That's the beauty. Now this has been done. Done.
Yes, sir.
Now coming to the superior part. Look at the axilla.
Yeah.
Yeah. See the axilla very clear?
Yes, sir.
Now how to enter into the frontal? I gave you a tip. Simplest way. I show you my best landmark. I have shown you
The beak.
beak. See your landmark. Which landmark is best always? Which is easily identifiable.
Yes, sir.
If your landmark is not easily identifiable, how can it be a good landmark? I will show in all cases different ways to open up the frontal. All cases different ways. Yeah.
Yes.
Good. See, this is your axilla. Go underneath the axilla. Sit.
Yes, sir.
Hello.
Yes, sir. Yes, sir.
Yeah. See the thickest of the bone there.
Yes, sir.
See the thickest bone there.
Yes, sir. That's, yeah.
Very thick bone. Can you see?
Yes, sir. Yes, sir.
See this technique. First of all, I am not looking at anything.
Beak.
Just underneath the axilla. See the axilla?
Yes, sir.
This is axilla.
Yes, sir.
This is a very thick bone. See this.
Yes, sir.
So the thickest bone in this region, that is beak.
Has to be beak.
Now where the beak ends, see I am going behind.
Yes, sir.
Can you see the where the beak is ending?
Yes, sir.
That is frontal.
And so much of, yeah, fungus debris came out.
Yes. But see, I am so relaxed at this point in finding the frontal sinus.
Yes, sir.
In this particular, I will show you different ways of opening the frontal. See, my bulla is intact below.
Yes, sir.
Can you see?
Yes, sir.
Keeping the bulla intact protects you from injuring the skull base, number one.
Yes, sir.
I told you, this is my beak. See this?
Yes, sir.
Edge of the beak. Showed you from my software that from this edge of this beak,
Sir.
my skull base behind is 1.25 centimeter.
Centimeter.
You
Yes, sir.
remember?
Yes, sir.
So if I am working here anteriorly, no risk. What my point?
Yes, sir.
See where I am working. I am working here anteriorly.
Anteriorly.
Nothing, no risk at all. What's it? नहीं वो दे. See, no time I am in the beak, I am in the frontal.
Sinus. Yes, sir.
I have seen only one thing as a landmark. First of all, middle metal antrostomy. Second is orbit. See this wall of the orbit?
Yes, sir.
Laterally.
Yeah,
This is my turbinate medially.
sir.
Best, best, best treatment of the turbinate is respect.
Yes, sir.
किधर खुल रही है? Best treatment of the turbinate is respect. Don't do anything to it.
जीरा पुशअप in between. पिकअप करने के लिए.
Okay.
See my frontal sinus in the depth of the beak.
Yes, sir. So basically, it's,
Sometimes your beak over projects.
yes, sir.
See, I am working just underneath the beak.
Yes, sir.
And see where it is leading to? Frontal.
Yes, sir.
You don't need to do anything fancy. My radiology has shown me where exactly I am supposed to go.
Yes, sir.
Reverse. See, this is my projection of the beak.
Yes,
That
sir.
is frontal sinus. Can you see very clear?
Yes, sir.
And see the mucosa all over is intact.
Yeah.
Now I am reducing this projection of the turbinate. Just reducing.
Sir.
See anterior surface of the turbinate.
Yes, sir.
This I am reducing for my better instrumentation.
Yes, sir.
And see what I am using? Adenoid blade.
Yes, sir.
Under which it becomes 70 degree. Under 70 degree it becomes front facing blade. See this?
Yes, sir.
Just reduce the bulla.
Sir. So,
For adenoid, he is using this same blades, but he does not use this for the blade.
And see the frontal again.
yes, sir.
Now I show you one instrument. This is my
Carries
no. This is articulated punch.
arterial bunch. Wow.
See this projection of the beak I am taking away.
Yes, sir.
See bites so good. And now see my frontal sinus
Yes, sir.
full of material.
Yes, sir. वो उसमें you can angle it at many points. Like it's not a one angle. You can change the angle. Thick mucin.
Very thick mucin.
Ah.
I will be using little powerful suction now.
हाँ हाँ तो बन रहा है.
See the suction.
Sir. तालियां बननी चाहिए उसमें तो बढ़िया शानदार.
This is our favorite powerful suction.
हाँ. Yes, sir.
This is liposuction.
Like. रखा पड़ा है बिल्कुल।
See the up there?
Yes, sir.
That is beauty of the liposuction.
Yeah, yeah, it came out probably in toto. Yeah,
It comes intact. See the beauty punching out the edge of the beak. That is the beauty of punching out the edge of the beak, which was over projecting.
sir.
And the instrument was articulated punch
Yes, sir.
from Carl stores. Now we'll use hydro debrider.
Minimum.
This was a small intersinus septal cell. Side wall. Side. See, that is the small intersinus septal cell medially,
Yes, sir.
and this is the party wall
Yes, sir.
to join with the main sinus.
Yes, sir.
I hope everyone is well oriented
Yes, sir. Yes, sir.
because I am using 70 degree.
Yes, sir.
This is widening to the maximum.
Yes, sir. Covered 91. 60 लग रहा है 60 90 तो इंट्रोड्यूस करने में बड़ा होता बस आता
The small septation left above.
Yeah.
This is the small septation left above.
है
This is how
सर
this small, this see under vision with the 70 degree. 70 degree is the key. See this?
यस सर
Once it comes to frontal sinus, widen maximum possible.
यस इम्पॉसिबल
See, this incomplete work of septation
We will be having
can bridge
holding and introducing the 70
with the scarring.
See the external picture.
ठीक है सर viewers want to see the way you are holding the 70-degree endoscope and the instrumentation from the external camera.
External camera लाओ भाई बोल रहा हूँ now we'll show you.
Sir.
Now give me hydro debrider first. Bringing the external camera. Meantime, I'll show you with the hydro debrider.
Yes, sir.
Cleaning of the frontal sinus. लगा. See the hydro debrider probe.
Sir.
See the hydro debrider probe.
Yes, sir. Seen, sir.
What up? Going in the frontal. See this inside the frontal.
Yes, sir. Yes, sir.
And now wash. Sir. See the frontal being washed.
Yes, sir.
और PIP में ले लो उसको. See, I have thoroughly washed the frontal.
Yes, sir.
Let's show you.
Okay. This is for everyone. 70-degree.
See the frontal.
Yes, sir.
देखो दो. Yeah, I will show you. Look at the frontal sinus.
Yes, sir.
See, medially is a small intersinus septal cell. See here,
Yes, sir.
we remove the party wall and made them one cavity. Can you see?
Yes, sir.
See the good frontal sinus.
Yeah.
That was the frontal sinus in this patient.
Yeah.
आगे के front excellent camera.
Yes, sir. देखा sir.
Now, let me show you how to introduce the instrument
Yes, sir.
and how to introduce the telescope together.
Sir.
इधर आओ मेरे पीछे. See, first introduce your telescope.
Sir.
Can you see my telescope going in?
Yes, sir.
Now, above the telescope, you can see
Section.
under vision of the telescope instrument is going in. Can you see?
Yes, sir.
Under vision, the instrument is coming out. See
Sir.
this.
Yes, sir.
Under vision going in, under vision going out. So, the 70 degrees below, instrument is above.
Sir.
Very clear?
Yes, sir.
See now the frontal sinus, very clear.
Sir.
This is beak again. For everybody to locate the frontal sinus, see the simplest way. This is axilla. Can you see?
Yes, sir.
Underneath the axilla is the beak.
Beak.
One can easily identify, and where the beak is ending,
Frontal starts.
that's it.
Sir.
No need to make it complex unnecessarily. This is
Sir.
the simplest version of how the frontal sinus can be seen.
On, sir.
Okay?
Yes, sir.
So we have seen the frontal sinus, we have seen the
Maxillary.
maxillary sinus. Now the ethmoidal skull base, and see the biggest structure there at the skull base is bulla.
Bulla.
See this?
Yes, sir.
Such a big bulla.
Sir.
Such a big bulla. And this bulla is going and inserting here on the skull base, here.
Yes, sir.
See here?
Yes,
That is
sir.
the anterior attachment of the bulla, and behind that attachment is the ethmoidal artery.
Sir.
So bulla itself protects the attachment of the ethmoidal artery.
Sir.
Secondly, see what I measured. This is the posterior edge of the, see the posterior edge of the beak.
Yes,
Can
sir.
you see here? Hello?
Yes, sir. Yes, sir. Seen, sir.
Edge
Yeah.
of the beak.
Yes, sir.
And see the skull base is 1.25 centimeter behind.
Centimeter behind it. Yes, sir.
See this?
Yes.
So once you're working at the skull base, don't terrify yourself with the skull base injury.
Sir.
Skull base is away. Okay?
Yes, sir.
Now the third thing. Now the next thing is removal of the bulla and seeing the anterior ethmoidal artery.
Yes, sir.
Wash. Let me go make the fill little better.
Sir.
Anybody has any doubt, disorientation, anything for me to show, please let me know. See my middle meatal enterostomy down,
Yes, sir.
frontal up. See
Yes,
that?
sir. Yes, sir.
This is with the 70 degrees. 70 degrees is my favorite. You can
Yeah.
rotate it anywhere and show everything.
Yes, sir.
Now see, this is bulla. Medially, I am going behind the bulla. See this?
Yes, sir.
See this?
Yes, sir.
See this? And gently fracture it out.
Yes, sir.
See, going behind and fracturing out.
Sir.
Towards me, away from the skull base. See that?
Yes, sir.
I have dismantled. It's a very big bulla.
Oh.
I have dismantled. I can take away with the.
Yeah.
See the remnant of the bulla and full of fungus.
Yes, sir.
Fungus takes away all the landmarks. So you have to be bit extra careful.
Sir.
Keep behind is the skull base.
Yes, sir.
Now I can see behind is the skull base. How's it? Yeah, 70 degree all the time. See this? All
Yes, sir.
fungus. See, I can see the glimpse of the skull base behind. I can see the glimpse of the skull base behind.
Sir, in condition like this, how will we prevent injury to anterior ethmoidal artery?
Yes. So, first of all, that's a great question. Number one, go behind and try to see. I have not gone in the depth. See, I am trying to see the skull base level. See behind that. See the skull base behind. Don't use any penetrating instrument. See the skull base. And in such situation, always stay in the. Don't use any force. Here is my anterethmoidal artery, I know. So your question,
Yes,
how
sir.
to prevent and damage to the anterethmoidal artery? See, why we are concerned with the damage to the anterethmoidal artery? Bleeding? No. The small vessel bleeding is hardly any issue. Reverse.
It retracts to the orbit and cause intraorbital hematoma.
When can you do this? When it is transected close.
Sir, your voice is
Hello?
clear.
So
Your voice
that-
is not clear.
that can happen when this artery is injured close to the orbit. Can you see the artery? This is artery.
Okay, sir.
So I am coming to your answer. That vessel can get retracted into the when it can retract to the orbit? When it is transected close to the orbit. Hello?
Yes, sir.
The artery leaves where it leaves close to the orbit, if it is transected there, it can retract. And
Is
that
there
will-
any audio visual person? Sir's voice is breaking.
voice is breaking.
Breaking.
Bulana yaar.
The audio visual person.
Yeah, coming. Let me know when the voice is clear.
Almost clear, sir. Sir, practically speaking, for a person like you, you can easily identify the anterior ethmoidal artery. But for juniors like us, in this situation, to identify anterior ethmoidal artery with the type of camera we are
That's what I am
working.
coming to. That's what I am coming to. So your point is valid that it can. Now, if transected, retract into the orbit, but where transected? When it is transected close to the orbital exit.
Yes, sir.
This is a very important point I am saying. The reason is once you are working in the vicinity of the vessel, never work close to the orbit, number one.
Yes, sir.
Because if you damage the vessel, it can retract into the orbit.
Yes, sir.
Second concern is if you work close to the skull base entry of this vessel,
Yes, sir.
you can give a CSF leak.
Yes, sir.
So for that, you don't work close to the medial end.
Yes, sir.
Don't work close to the skull base medially.
Yes, sir.
So, the best way to prevent injury to this vessel is work close to the, in the middle of the course between the medial and lateral lines. Got my point?
Yes, sir.
If you work between the medial and lateral ends, there's no question of giving any significant complication. In the
Yes.
worst to worst situation, even if you injure the vessel,
Yes, sir.
it will not give any major complication because it cannot retract into the orbit then.
Yes, sir.
See, it had pushed the orbit. This is lamina which is dehiscent.
Yes, sir. Sir, in this situation, can we, what you say, empirically bipolarize the area of anterior ethmoidal artery so that chances of injury is less?
No, 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 no. If you don't know where the vessel is, what will you bipolarize?
Means the expected area of anterior ethmoidal artery. Expected
That area can be too big.
Yes, sir.
See this? This is close to the orbit.
Yes, sir.
Now this is lamina papricia. Let me clean and show you something very, very important anatomy. Here it is all distorted, you can see.
Yes, sir.
See the frontal in view. Wash the.
Yes, sir. Sir, after doing the frontal work, can we switch on to, for juniors like us, to 0 degree
Yes,
so
sir.
that we are more oriented, matlab doing surgery by ourselves. If we switch off to 0 degree, we are more
Yeah,
oriented to anterior,
I will.
all those areas.
In a minute's time, when the anterior ethmoidal roof work is over, I will switch off. See now, to orient again at this level. This is a narrow supraorbital recess.
Yes, sir.
Narrow supraorbital recess, and whenever supraorbital recess is there, anterior ethmoidal artery is immediately caudal to it. Always. Now see narrow recess, there is some fungal mucin. See this?
Yes, sir.
In this disease, if you leave the slightest of the mucin, the same story will create problems. See now?
Yes, sir.
See anteriorly the frontal sinus proper. Behind that, this is supraorbital recess. See this?
Yes, sir.
And where this recess ends, this is the ethmoidal artery. See this ethmoidal artery here?
Yes, sir.
Very clear?
Yes, sir.
Again, this is frontal sinus. This was intersinus septal cell communicated.
Yes, sir.
This is supraorbital cell. This is again behind.
Yes, sir.
For your information, always the intersinus septal cell is the most anterior cell. See the most anterior there up.
Yes, sir.
Okay?
Yes, sir.
Then comes the frontal sinus.
Yes, sir.
Then comes the frontal sinus. This intersinus septal cell named frontal sinus. This is frontal sinus, and then behind the frontal sinus, here is the supraorbital recess, narrow. This is very narrow.
Yes, sir.
You will see in the cases, other cases, the big supraorbital recess. This is supraorbital recess behind the frontal sinus. Again, why I am showing? This is intersinus septal cell medially, frontal sinus, and behind the frontal sinus supraorbital, and behind the supraorbital, here it is the anterethmoidal artery. Clear?
Yes, sir.
Very clear. This is anterethmoidal artery. See
Yes.
this? So, in cases where you are doubt, you are not sure of the vessel in that region, you work neither too medially, neither not too laterally in the middle of the course. So even if you injure the vessel, you can bipolarize it.
Yes, sir.
Nothing will happen. Got my point?
Yes, sir. Sir, what is the anatomical landmark for identify anterior ethmoidal artery? Anatomical landmark.
Anatomical landmark number one is it is caudal to the supraorbital cell.
Yes, sir.
That is one of the best landmark one can think of.
Yes, sir.
No, fact nahi hai, periorbital.
Yes, sir.
See now the picture. So that now I change to 0 degree. See, this is maxillary sinus below,
Yes, sir.
frontal sinus up there. This is
Yes.
lamina pepracia here.
Yes, sir.
See this? And the middle turbinate is intact all the time. See this?
Yes, sir.
This is middle turbinate here. This is lamina laterally, which is part.
Yes, sir.
This is back anteriorly. The frontal there. This is anterethmoidal artery, and that is skull base. That clear?
Yes, sir.
Now I'll change to 0 degree. See, all structures are so pretty clear.
Yes, sir.
Full telescope, ये कैमरा दूसरा मंगा. See now,
Yes, sir.
this is all periorbita
Yes, sir.
because we know it is dehiscent.
Yes, sir.
All fungus, all fungus. Now, once you have done this, you are supposed to enter into the posterior group of sinuses.
Yes, sir. Sir, in doing this AFRS cases, what are the things we have to send for histopath other than the polyp and the mucosa? This mucin also and this fungal debris also.
No, not required. This is just as a theoretical importance. This is
Okay.
not going to change your treatment. Now,
Then
see the next important step, what I am doing is working at the medial orbital angle. See this?
yes, sir.
And defining the floor of the orbit. Why? Sometimes you have a Heller cell here, which one can easily overlook.
Yes, sir.
This is an important landmark for many regions, I tell you.
Yes, sir.
This is medial orbital angle. Can you see the level of the orbit now better?
Sir, your voice is breaking a bit.
See the level. अरे यार voice क्यों जा रही है? See the level of the floor of the orbit.
Yes, sir.
That's a great landmark for work behind.
Yes, sir. The picture is lost, sir.
Yeah, just a moment.
Yeah, came back.
ये रिमोट वाला लगा. See the medial orbit angle?
Yes, sir.
Very clear or not?
Yes, sir.
See the picture?
Yes, sir.
Now I am with 0 degree.
Yes,
See
sir.
the frontal you have left above.
Yes, sir.
Frontal is left above. This is the anterothoracic artery.
Yes,
That
sir.
is ethmoidal roof. That is
Yes.
lamina papracia.
Yes,
And
sir.
this is medial orbital angle.
Yes, sir.
At this point, this is my turbinate. See this?
Yes, sir.
I told you in the morning, if there is disease medial to the turbinate, can you see this?
Yes, sir.
If I don't remove this inferior part of the turbinate, see this?
Yes,
This
sir.
disease is cannot be addressed properly.
Yes, sir.
So leaving the upper part of the turbinate,
Yes, sir.
partial turbinectomy here is the need to improve
Yes.
the outcome.
Yes, sir.
Yes, I am leaving the upper part of the turbinate,
Yes, sir.
leaving the upper part. See this?
Yes, sir.
This is planned.
Yes, sir.
This is planned turbinectomy wash.
Yes.
Partial turbinectomy. पहले इसको दूसरा मोड़. See, all this disease hidden behind the turbinate is now in front of you.
Yes, sir.
See all this polyposis.
Yes, sir. So in all the cases, as we are removing ground lamella also, so partial turbinectomy of middle turbinate is done in all the cases.
No, not all cases. If you have a significant disease medially.
So matlab, we may leave behind the ground lamella.
Ground lamella has been removed. That's why we have gone behind.
Yes, sir.
The disease. Massive mucosal disease. Now,
Yes.
cabinet. Can you see?
Yes, sir.
It's thinned out.
Yes, sir.
This is ethmoidal cavity. This is superior turbinate.
Yes, sir.
I am taking away the superior turbinate inferior part, not the upper part.
Yes, sir.
The lower half of the superior turbinate is safe in terms of removal as it doesn't contain the olfactory fibers. Only the upper part contains the olfactory fibers.
Yes, sir.
And see, this is medial to the superior turbinate is what? What is this?
Sphenoid sinus.
Ostium.
Ostium opening.
Yeah. So you have to be. See this massive polyposis.
Yes, sir.
Now widen. See this? See my middle turbinate. It is lying close to the. This is line.
Yes, sir.
See why we refer to the maxillary line whenever required. This line you can continue horizontally. Your sphenoid sinus ostium is either at this level or below.
Yes,
This
sir. Yes, sir.
is a maxillary line.
Sir, please repeat what is exactly the maxillary line?
This is floor of the orbit. See this?
Yes, sir.
If I draw a line here behind,
Yes, sir.
in sphenoid sinus work, to
Yes.
look for the ostium, we should not look for ostium above that.
Yes, sir.
Either at that level or below that, because above that, this ostium is close to the skull base.
Yes,
You are
sir.
very close to the skull base. And that should be avoided. Okay?
Yes, sir.
Just to show you. See, this is the roof.
Yes, sir.
You see?
Yes, sir.
And this is all inflamed material which was causing problem.
Yes, sir.
Sir, while doing FES, what are the precautions we should take that in future, if head flap is required, we may not be injuring its blood supply?
Yeah. So don't widen go to this section. Don't widen the sphenoid ostium inferiorly too much.
Yes, sir.
My first work is being completed. I told you we need to give in AFRS wide openings.
Yes, sir.
See fungus coming out. And in next 2 minutes we'll be free.
Yes, sir.
Sir, in this case, what are the
Now,
materials?
powerful section. Look at this. This will bring out everything.
Yes, sir.
See this?
Yes, sir.
The beauty of the power section.
Yes, sir.
So AFRS should have power suction because this material is very cheesy. It doesn't come out so easily. Hydrodebrider.
Yeah. Sir, there
Sphenoid
is,
sinus. See, I am not doing anything inside the sphenoid.
yeah.
Only blunt instrument suction. Thorough irrigation. We'll do thorough irrigation.
Yes.
We'll use the hydrodebrider, but no sharp instruments.
Yeah. Sir, one theoretical question.
Yeah, please.
If this is a allergic fungal sinusitis, it should be on both sides as patient is
always.
feeling,
Mostly
as
it is
patient is
unilateral.
feeling the fungus on from both sides.
Mostly it is unilateral and it can progress to bilateral if not effectively treated. What is it? Secondly, mostly to begin with, it is unilateral.
Yeah.
If unilateral is treated effectively and post-operative douching are done, immunotherapy given bilaterally doesn't progress.
Yes, sir.
Sir, what is the power suction you are talking about?
This is liposuction. 1 HP.
How do we get it?
From the you can get from the vendor telling them the same section which plastic surgeon use for liposuction.
Okay, sir. Sir, in this case, what other material we were going to give to the histopathologist, and what specifically
We have taken a sample of mucosa,
Yes, sir.
polypoidal
And what other
mucosa.
things we will ask them.
Yeah. Fungus I am not taking because that is not going to change my management anyway. Fungus is confirmed for diagnosis, so there is no
Yes,
point
sir.
in just theoretically or for any reason if you want to prove, then it is different. But
Yes.
from management point of view, that is not going to change.
Yes, sir.
Now I am creating this mega enterostomy.
Yes, sir.
So anything we will be doing that to the septal spur?
Not really, it is not bothering.
Okay, sir.
In the AFRS, if there is no opposite side disease, better
Yes,
not to contaminate unnecessarily.
yes, sir.
See the mega middle metal enterostomy.
Yes, sir.
There are variety, different ways of defining mega middle metal enterostomy. Here,
Yes,
mega
sir.
middle metal enterostomy to me is flush with the posterior wall. See that?
Yes, sir.
You can remove the inferior turbinate partly and flush with the floor.
Yes, sir.
You can remove anteriorly completely medial wall until the nasolacrimal duct.
Yes, sir.
See now, final picture. Yeah, give me over there. Hydro. So we have used hydro debrider in maxillary sinus.
Yes, sir.
We have used hydro debrider in frontal, and now in the, see this?
Yes, sir. Sphenoid sinus.
No.
Sir, the site
Yes.
for posterior
Yes.
neuropathy.
Water jet.
Yes, sir.
See the stream, water stream.
Yes, sir.
See the fungus coming.
Yes, sir.
Full water jet.
Yes, sir.
So even if, see, all the dependent sciences have been washed off
Yes, sir.
and it looks good now.
Yes, sir. Sir, can you demonstrate the site for posterior neurectomy you were talking about?
Yes. I will show you. I told you in the morning.
Yes, sir.
See, my full house face on this side is done. Can you see?
Yes, sir.
Very clear?
Yes, sir.
Pardon? Now, for the, what they call it? Posterior nasal neurectomy.
Yes, sir.
So simple. See the ergonomics. See now.
Yes, sir.
This is the posterior edge of the middle turbinate.
Yes, sir.
See, behind here is the pterygopalatine fossa. See that?
Yes, sir.
The artery comes out just below the middle turbinate here.
Yes, sir.
From here. Okay?
Yes, sir.
And from here, through this bone,
Yes, sir.
through this perpendicular plate of the palatine bone, the
Yes.
nerve comes from the middle turbinate, from the sphenopalatine foramen,
Yes,
and
sir.
this bone to the inferior turbinate, which is below.
Yes, sir.
That is the only way where the nerve passes through. Okay?
Yes, sir.
What I am doing now, prophylactically.
Yes, sir.
See my cobbletter?
Yes, sir.
Yes. Can you see this 1 square centimeter area?
Yes, sir.
all the nerve passing from the sphenopalatine to the inferior turbinate. See, this is inferior turbinate.
Yes, sir.
This is inferior turbinate.
Yes,
And
sir.
this is the area from where all the nerves pass through. See this?
Yes, sir.
This is coblated.
Yes, sir.
So you don't need to elevate anything. Posterior nasal nerve pass through that area are automatically
Yes, sir.
denervated.
Yes, sir. Sir, you do this in every cases of face?
No, in allergic ones. I told you AFRS and CCAD are two variants of allergic.
Yes, sir.
Yeah. These two have almost 100% incidence of allergic rhinitis because the etiology is allergy only.
Yes, sir.
See, this is the area where we need to coagulate.
Yes, sir.
You damage the mucosa and the nerve through it. Now that's the final picture. First of all, we have washed all the dependent sinuses. See our limits.
Yes, sir.
In OPD, you should be able to do full surveillance.
Yes, sir.
To the crowd. See this? No bleeding, nothing.
Yes, sir.
See the skull base. Above is the frontal sinus.
Yes, sir.
See above the frontal. The middle turbinate is here medially. This is lamina papyracea. That is sphenoid sinus, maxillary sinus.
Yes, sir.
Everything done.
Yes, sir. Sir, we can use bipolar also for the posterior neurectomy.
Yes. But see, cobbleter is so handy.
Yes, sir. Sir, by chance, if we are going to remove a part of inferior turbinate, if it is diseased, what is the best part we can remove without any functional deficit to the patient? Or if inferior turbinate hypertrophy is blocking the nose, then what is the best part we can remove?
I will show you in any of the case showing inferior turbinate hypertrophy. Okay?
Yes, sir.
This patient doesn't need. See this.
Sir, in this patient, the vision loss is reversible. What are the prognostic?
100% because this was because of the fungus in this region of the optic nerve
Yes,
and
sir.
made the wall dehiscent and the inflammatory mediators led to this.
Yes, sir.
This is bound to come back.
Yes, sir.
This was partial because of this. And
Yes.
this is bound to come back.
Yes, sir.
See now the picture. You can see in your OPD with your 0 degree.
Yes, sir.
See in this endotype, number one, the specificity of this endotype, AFRS.
Yes.
Wide antrostomies. Can you see?
Yes, sir.
Because you want to do a surveillance for life. You want to push the steroid deep inside. This is steroid dependent. Allergy. Complete. See the surveillance. You can do this surveillance in your office, in your OPD only. Now, whatever patient pushes the steroid, they will go, all the entire solution will go deep into the sinuses easily. There is no obstacle. See this?
Yes,
No
yes.
middle turbinate and nothing is there to obstruct. I hope the picture is good there.
Yes, it's very good. Satish boss, I'm Shailesh here. I have two questions.
Yes, please.
Whether any draft 1 or 2 procedure needs to be done in such patients where we need to widen the frontal sinus ostium? That is my first
Yes.
question.
Yes,
And
yes.
second question is,
Don't think twice. If you feel,
hello?
yes, you are right. Hello.
Yes, boss.
If you feel like your passage is not good, the
Yeah.
passage is not adequate to,
Opening to the frontal.
there was a little beak which was projecting. Remember?
Yes, that's what. You punched it out. So instead of that, creating a flap and draining out the beak would have given the more better approach? Or
Yes.
this
See this. See this. This was the beak which was projecting. See this? Yeah. Can you
So
come?
this is septum, where the
No,
infiltration.
no. I have come here now.
Okay.
See this.
Yes.
This is the beak which was projecting.
Yeah.
So with my articulated punch, I punched out this beak to widen.
Yes.
This was the projection.
Yeah.
Lower one. See the beauty what CT scan gives you. Number one, this safety margin. This safety margin.
Yeah.
This gives you very clear that how much is the space. Number two, see how we came. We came with a 0 degree here. Identified the beak. Remember?
Yeah.
And where the beak ended, we went in. See that?
Yes.
This is always like that.
Yeah.
Cannot change.
Okay.
If you are lost in frontal sinus for any reason, any time, any point of time in life, first identify the axilla.
Okay.
Go underneath the axilla, identify, feel the hard bone. That is the hardest bone, and this is the hardest bone. See the thickness of the bone.
Yes.
And then following that bone, keep going behind.
Yeah.
No worries. You are more than centimeter away from the skull base. The
Yes.
moment where you find the opening, you are still centimeter away. More than that.
Yeah.
See this zone. This is the safest zone of entire paranasal sinus. Can you see?
Yes. Yes.
This is the safest zone.
Yeah.
Now, for people who discuss about the draft, next कौन सा लिया? Anupam, when is the next? For people who have queries regarding the draft, I will show at least 2 or 3 drafts in these 2 days.
Yeah.
See, the area which you work in. Can you see this?
Yes. Yes.
Is there any critical structure there? No.
Got it.
Draft is the simplest procedure, believe me, and I want to shatter your fear regarding the draft. Everybody here seeing this presentation, surgical work, everybody should be able to do draft himself.
Yeah.
Believe me, don't need to terrify. The draft is the simplest surgery in the simplest region, I would say. See, the skull base is far behind.
Yeah.
What we do in draft, we improve our access into the frontal sinus. See like this?
Yes. Yes.
When we come from here, we remove this bone. That's it.
Yeah.
If you remove this bone, you have a straight access into the frontal. I will show in this case. Next case. Okay?
And Satish,
Yeah.
I have one more question, like which you created a mega middle metal enterostomy up to anteriorly up to the nasolacrimal duct.
Pardon?
So-
Yeah.
Anteriorly up to the nasolacrimal duct.
Yes, sir. Yes, sir.
But anterior to the nasolacrimal duct, that niche, the corner of the maxillary sinus was still invisible. So would you advocate in these patients where we can do the pre-lacrimal approach, remove the bone and get into the anterior-most corner of the maxillary sinus in order to inspect and in order to confirm whether we have removed the complete fungals or not?
Yeah, yeah.
To recommend this.
Yes, I got your point. So what 2 things I did to ensure that? Number 1, I came through the sublabial route
Yeah.
and came with a 40-degree blade.
Yes.
40-degree somersaulting in the entire maxillary sinus, including the anterior one. Number 1.
Okay.
Under 70-degree vision. So it was all visible. Number 1. Number 2, the irrigation deep into the maxillary sinus everywhere, pushing my fungus out.
Okay.
Number 3, had this been a papilloma, some tumor or something else,
Yeah.
where the bone erosion, the bone involvement requiring drilling, I
Yeah.
would not do by this approach. I would go by the pre-lacrimal or Denker's approach.
Okay.
In those situations, I still prefer the Denker's. I tell you the reason.
Yeah.
You can remove that limited involvement of the anterior medial part by the pre-lacrimal,
Yeah.
and you can close by the suture again, mucosa.
Yes.
So only the clearance part is amazing. They're the same, I would say, exposure what is given by the Denker's. But the problem is follow-up.
Yeah.
Again, you are blind in follow-up if you go by the pre-lacrimal approach because you have to close again.
Yeah.
In Denker's, you open up everything and you have everything in front of you for follow-up.
Yes.
So that's a difference in the pre-lacrimal and Denker is not during the surgery. It is important in the follow-up. In Denkers, everything is in front of you. No need of radiology in the future.
Yeah. One more question related to these Denkers.
Yeah.
That people complain that after doing Denkers, there is a nasal LR collapse. What is your take on this?
Yeah. Number one, I will show you in,
And
if
how
I
to
show you
prevent
Denkers in one of the case, nasal LR collapse will happen only if you go far anteriorly.
Yeah.
Only,
How do we define this far anterior proposition?
yes, yes, yes. I will show you. I will show you. See this. Can you see the anterior edge?
Yes, we can.
This is piriform aperture.
Yeah.
See this?
Yes.
And what is this? This is ala.
Yeah.
This is lower ala. Can you see?
Yes.
This is where I have scored. This is lower ala. By removing, in order to remove this, if you come more than a centimeter anteriorly, you are likely to injure the ala.
Okay.
So the crux to prevent this is, with your cobblator, feel this edge of bone and make a mark over there so as to define your anterior limit.
Okay.
And don't come even a millimeter anterior to it. Forget about the centimeter. You have a margin of centimeter, but still don't try to come even a millimeter anterior to it. The reason being, if you come even few millimeters anterior, this tissue which goes off, pulls the ala in later on.
Yeah.
So stick right onto the bone. In one of the case, I will show you. Even if it is not needed, I will show you this step.
Yeah.
That
And
just,
if at,
just feel on the bone and make a mark over it with a cobblator.
yeah.
That's it.
And if at all it happens, then what do you suggest? What to
Then
do?
you have to put a cartilage to support ala. That is not difficult. But just you have to put a lateral LR rim graft.
Lateral LR strut graft.
Rim graft. Rim. You have to put a rim.
Yeah, but rim won't strengthen. It just puckers it up, no? So you'll need something from the below upwards to push the LR upward and
Yes.
out to.
So it a little longer one to rest on the bone
Yeah.
or laterally. Yeah. And it strengthens. It works well.
Okay.
So
Okay.
that is not difficult, but you can certainly avoid this. We have done so many dankers. Every day we have been doing dankers. The crux is just feel this bone and make a mark with a cobblator over it. Not to go even a millimeter anterior to it.
Okay. Okay.
The soft tissue anterior to it should not be eaten away. Otherwise, the ala may retract. It is not injuring the ala directly which is responsible for ala retraction. The supporting tissue underneath should be supported.
Yes.
So now the next question, next case we are taking. Any questions regarding this?
No. Very much clear.
Okay. Thank you for your patience. Now coming to the next one. That's a very interesting one. Prahlad, no? This patient, see this. Again, eosinophilic disease. Video. कहाँ गया वो? अजय, video. तो वीडियो बनाया था ना एंडोस्कोपिक प्रहलाद का पूछ हेलो जा रहे हो
Yes. Yes.
अरे बॉस थैंक यू अरे बॉस वेलकम सर हेलो
Yes.
yeah are you getting the scan on the screen?
Yes. Yes.
Let me show you. Can you see this? See, I'm going from anterior to posterior.
Yeah.
See the frontal sinuses, intersinus septum in the
Yeah.
coronal.
Yeah.
Beak below.
Yes.
No cell so far.
Yeah.
Let me come again from most anterior part. Most anterior, going behind. Going behind. Some cell is appearing here. Can you see?
Yes.
Looking like isolated cell. Can you see?
Yes. Yes.
Anybody, what it can be?
Cell in the intersinus septum?
No, forget about this. Is intersinus septum. This is intersinus septal cell. What is this cell? Again, let me show you. Just a question. What is this cell? This one. Hello?
Yes, listening, boss.
Yes. अरे आ गया. What is this cell? I hope it is very clear.
Yeah.
This is isolated, looking like isolated cell in the sphenoid, the frontal sinus. Can you see?
Yes, we can see.
And anybody can label it as a. Any guess? Isolated cell in the frontal sinus. Looks like isolated cell. What can be? Hello?
Maybe type 3, type 4 cell?
Yeah, it looks like type 4 cell. Isolated cell in the sphenoid frontal sinus looks like type 4 cell. Okay?
Yeah.
Now let me reconstruct and see the value of dynamic imaging. That's why printouts are jokes. See this. See the cell?
Yes.
Let me take my cursor into the cell. Can you see the cell?
Yes.
Look in the sagittal.
Yeah.
What is this now?
It's a frontobular.
Yes. So the diagnosis is now very clear.
Yeah.
What it was looking like a type 4 cell, why it is frontobular now?
Has an attachment going towards the bulla.
Yeah, see this. This is extending from the bulla deep, far deep into the frontal sinus along the posterior wall. Can you see?
Yes, yes.
Is Dr. Amit there?
No.
Not there in the, he was asking about the frontobular cell. See, this cell is a posterior cell attached to the posterior table. Can you see here?
Yes.
And going far deep into the frontal sinus. Now the treatment for this cell is you have to punch out this anterior wall.
Yeah.
You have to punch out this anterior wall. See this. See this cell. You have to punch out this anterior wall. Can you see here?
Yes.
And flush with the posterior table. That is
Yeah.
the treatment.
Hmm.
If you try to go behind this cell, you will end up injuring the skull base. So this is a big one, frontobular cell. I hope the diagnosis is very clear to everybody.
Yes, yes. Very much.
Yeah. Now see, what is there anteriorly? This is a small Agarnage cell. Can you see?
Yes.
And this is the frontal drainage pathway. See
Yes.
the drainage pathway?
Yeah.
Can you see between these two cells?
Yes.
That's the drainage pathway. So it is compromised by the big frontobular cell behind and the small Agarnage cell anteriorly. The culprit is this cell. Now, while coming from anteriorly here is the beak.
Yeah.
Here is see the lower edge of the beak.
Yes.
Coming from here, how will we reach out to this dome of the cell?
Just removing the beak.
So that will require a draft.
Yeah.
What's my point?
Yes,
So-
but the frontal recess is also opening in between the agar and the frontobular cell. So do you
It is very
think that
narrow.
frontobular cell is also draining downwards?
Yes.
So do you still feel like widening this opening?
Yes, we have to widen it. I have to widen this opening from here to here. From here to here. I
Okay.
want everything out to drain the frontal and to allow my solution, steroid solution to penetrate deep into it.
Okay.
Got my point?
Yeah, got it.
Now, if I come with my endoscope, the biggest problem is how will I reach out there safely?
Yes.
This is the obstacle, and this most likely will require a
Yeah.
drilling of this beak, which is known as draft 2B for this patient I will be doing.
Yeah.
Is that clear to everybody? See, the most important thing in the diagnosis is the CT scan for this difficult anatomy. And this cannot be diagnosed so well without this dynamic CT scan. That is a joke. Otherwise, one can considering this, see this, considering this coronal section, anybody would consider easily with a snapshot, it looks like type 4 cell.
Yes.
See this? And if assuming type 4 cell, you tend to go behind the cell.
Yeah.
If you tend to go behind the cell, what is going to happen?
May land up in and injure the skull base and damage the posterior table.
Oh, how life-saving this CT scan is, how life-saving is this understanding of CT scan dynamically. That's what I want to propose.
Yes. Yes. Message.
Many a time, you know what happens? Patient brings a single printout, got the CT scan done somewhere else.
Yeah.
Believe me, we are forced to get a repeat CT, 0.5 mm CT scan with all dynamic, imaging. Look at this. Look at this imaging, 0.4 mm scan. Can you see?
Yes. Yes.
Can you see at the left lower end?
Yeah. 0.4.
Every single move is moving by 0.4 mm. You cannot miss any structure of size more than 0.4 mm.
Yes.
That is the beauty. So CT imaging is amazing. It's a life-saving thing. It gives you complete perspective of the surgical work, what you are going to execute. Without this 3 dynamic CT scan, a person who is trying to do a complete job can land up in complications easily. And in frontal sinus, either you will end up doing an incomplete job, or if you try to do completely, you will end up giving complications. So the complete understanding of the work what you are going to do is best established by a good dynamic CT scan. Okay?
Yes.
So I will show you at least one side of this. Now another anatomy, see on this patient. If I'm going behind, can you see the intersinus septal cell?
Yes.
Now see where it is communicating. See, number one, what I said during the last case. This is frontal sinus going behind. See, I am going behind.
Yeah.
I am going behind by 4 millimeter every time. Now the first cellularity in the paranasal sinus anteriorly.
Yeah.
First cellularity, again I am repeating. First cellularity in the paranasal sinus anteriorly. What is this?
The intersinus septum.
Cell. The first cell is intersinus septal cell. Don't forget, this is most anterior one. I showed you in the last case, if you remember, the most anterior one was intersinus septal cell medially.
Yes.
So intersinus septal cell is medial anatomy, most anterior one. And if I am going behind, see now I am going behind. See where it is communicating. Can you see?
Yes. Yes.
To the right side.
Yeah.
So what you need to do is, in this situation, when you do this right side work, you have to flush this septa and give a common opening. What we did in the last case. You remember?
Yes. Yeah.
So we should be able to know, execute, answer to each and every problem, each and every situation. What to do if it is a frontobular cell, what to do is a type 3, type 4 cell, what to do is agar cell, what to do if there is a supraorbital cell, intersinus septal cell, because these answers are required to do a good frontal sinus work. Good frontal sinus work requires a good 3-dimensional understanding of the CT scan anatomy dynamic. Number 2, good 70-degree work, 70-degree orientation, and long curved instruments. See now if you go behind, this is the agar cell on this side. Agar cell on this side. This see the cribriform plate now?
Yes.
This is shallow. See, this is supraorbital, this is shallow. Like in the previous case, not very deep. See, it is going up to here only. In the last case, we saw the supraorbital space was very shallow. And it was behind the frontal sinus. Remember?
Yes, yes.
Let me show you for those who didn't understand what I'm trying to say. In the last case, remember what I showed you medially intersinus septal cell, then frontal sinus, and behind the frontal sinus laterally was supraorbital. Remember?
Yes, sir.
Remember?
Yes, yes.
Now see, in the same situation here. See, anteriorly, intersinus septal cell. Then comes the frontal sinus.
Yes.
And then behind, this is supraorbital cell. This is behind.
Yeah.
I have gone far behind now. Let me put my cursor into it. See this. My frontal sinus is left far anteriorly and this cell is far behind.
Yes.
Okay? And this is supraorbital because this cell is lying. See this cell. See this cell lying above the orbit. Where is the orbit?
Yes.
See this orbit below. This is orbit below. And this cell is lying above the orbit. I hope very clear.
Very clear, very clear.
See the supraorbital cell in all planes. This is the supraorbital cell. This is the orbit. This is above the orbit. See this?
Yeah.
But not going very posteriorly because this cell is not very pneumatized. We have seen the supraorbital cell pneumatizing even right up to the zygoma there with full of pus up to the zygoma. So the anatomy can be variable. You should be able to pick up from the CT scan. Okay?
Okay.
Now behind there is not significant. This is all regular polypoidal disease. Yes, important anatomy behind is it Onodi cell. What is Onodi cell? How can we pick up Onodi cell? See this. See, I am going behind.
Yeah.
This is the sphenoid sinus on this side.
Yes.
This is the sphenoid sinus on this side.
Yeah.
And see this cell above the sphenoid sinus. Can you see?
Yeah.
And this is in contact with the optic now. This is optic now.
Yes.
Sphenoid sinus is pushed inferiorly.
Yeah.
And this cell is about, see, this is postethmoidal cell. I have come anteriorly. See this?
Yeah.
Now my cursor is in the postethmoidal cell. This is postethmoidal. Keep an eye on my cursor. Now I am going from here behind in the postethmoid. Behind. See this?
Yes.
Following this postethmoidal cell. Where I have come?
Sphenoid sinus.
Sphenoid is below. I am in the Onodi.
Onodi.
That's why, see again, if I open the postethmoid here and
Yes,
follow
sir.
this Onodi cell in the postethmoid
Yes, sir.
without realizing that this is Onodi and keep going behind. See my cursor, keep going behind. Where I am going to go and hit? Optic now.
Yes, sir.
So in any given situation, when you open the postethmoid, stay medially. See, this is superior turbinate. Stay
Yes.
between the superior turbinate and septum and see here the sphenoid sinus is.
Yes, sir.
I hope you understood what I'm trying to say.
Yes, sir. Sir, asking one question. Any horizontal septation in sphenoid sinus signifies it has Onodi cell?
Yes, and you can see dynamically, you can relate this.
Yes, sir.
Don't believe in single snapshot. It's the time of dynamic imaging. And
Yes.
that's why I showed you. See, I showed you this is postethmoidal cell and see how it is going.
Yes,
Now, yeah, you can see in all planes. All three planes, you can see the same anatomy. What Onodi means, you must know this.
sir. Yes, sir.
See this Onodi cell in all planes. Now, one by one. Can you see in the sagittal one?
Yes, sir.
This cell, the postethmoidal cell, has grown above and beyond the sphenoid sinus. The sphenoid is here.
Yes, sir.
This is the anterior wall of the sphenoid.
Yes, sir.
And see this cell, how it has gone beyond the past the anterior wall of the sphenoid.
Yes, sir.
See how much it is behind the anterior wall of the sphenoid. Can you see?
Yes, sir.
See this. This is the anterior wall of the sphenoid. See this?
Yes, sir.
And this cell has gone almost more than a centimeter behind the anterior wall of the sphenoid.
Yes, sir.
See this?
Yes, sir.
If you keep doing post-ethmoidal work without realizing where you are, you can go behind this, and here is the optic now.
Yes, sir.
You can go easily and hit the optic now.
Yes, sir.
See? Now the same onodi cell you see in the axial plane. See this axial plane. See the axial section? Hello? Hello?
Yes, sir. We are listening.
This is the onodi cell, this one.
Yes,
And
sir.
this is the sphenoid sinus. And the optic now coming from laterally.
Yes, sir.
See this optic now coming from here is in
Yes, sir.
contact with the onodi, not in the sphenoid. This is the optic now coming is in contact with the onodi.
Yes, sir.
So beware of onodi situation in any given case for that matter. Consider every patient as an onodi cell. The
Yes, sir.
moment you enter into the sphenoid sinus, moment you enter, this is superior turbinate. Moment you enter in the posterior ethmoids,
Yes, sir.
this is superior turbinate. Take a path medial to superior turbinate. See this? Whether
Yes,
or not onodi there,
Yes,
take a
sir.
medial path. This is septum.
Yes.
Between the septum and the postethmoid, and follow that and keep going behind. See, I am in the sphenoid.
Yes, sir.
Onodi is let above. I hope everything. Anybody, any question?
Yes, sir.
Sir, will you show suprabular and supraorbital again?
Okay. Suprabular and supraorbital. Suprabular cell in this case has extended in the frontal sinus to have become frontobular. I showed you. See this. See this. This suprabular cell has gone extended into the frontal sinus to have become the frontobular cell. Can you see?
Yes, sir.
So this is suprabular cell which has gone in the frontal sinus is known as frontobular now.
Right.
And supraorbital, I had shown you this is supraorbital. Frontal sinus anteriorly and supraorbital behind. Above the level of the orbit, this is orbit.
Right.
See, this is the frontal sinus. This is the party wall between these two, and this is shallow supraorbital recess.
Sir,
Yes,
that means the supraorbital cell is always behind the frontal sinus, isn't it?
always. That's the point. That's the point. That's what I'd shown earlier. I will show you it again and again. The most anterior is the medial cell, intersinus septal cell, if it is. Then frontal sinus. If you come behind the frontal sinus, will be the supraorbital cell. That is laterally going above the orbit. Okay.
Yes, sir.
Another thing. See, this is the maxillary sinus in the sagittal cut. Can you see this?
Yes, sir.
This is orbit. See the eyeball.
Yes, sir.
Let me make the soft tissue contrast. Soft tissue window. See this orbit eyeball?
Yes, sir.
This is supraorbital cell there.
Yes, sir.
This is orbit.
Yes,
This
sir.
is maxillary sinus. Can you see?
Yes, sir.
And what is there behind this? Anybody?
Sir,
Communi- communicating to the orbital apex. Yes.
pterygopalatine fossa.
Pterygopalatine fossa, and this is leading inferiorly as
Infratemporal fossa and
this is
then the
inferiorly as greater palatine
palatine.
canal.
Yes, sir.
This is greater palatine canal. See this opening in the palate.
Yes, sir.
Above it is opening in the orbital apex. This is inferior orbital fissure.
Yes, sir.
And below, this is pterygopalatine fossa communicates above with the orbital apex as inferior orbital fissure.
Yes, sir.
below with the palate oral cavity through the greater palatine canal.
Yes, sir.
And behind with the anybody
Behind is the thyroid plates.
behind what it communicates with. See, this is pterygopalatine fossa
Yes, sir.
communicating laterally with the infratemporal fossa.
Yes, sir.
Superiorly, inferiorly, you have seen, and behind it is communicating here with the. This is pterygoid canal.
Yes, sir.
This is pterygoid canal, and this is foramen lacerum.
Yes, sir.
See, this is carotid artery running over the foramen lacerum.
Yes, sir.
Above is the carotid artery, below is the foramen lacerum, and from here it is communicating to the median canal to the. This contains the median. Now we were talking about in the morning,
Yes,
going
sir.
to the pterygopalatine fossa. I hope it is very clear.
Yes, sir.
So let's start the second one. उन दो को खिंचवा देना, उन दो को खिंचवा देना, बता दिए ना वो जो इसमें थे तो बोले वो इसमें थे ना जो उनको करवाना है कराया नहीं क्या अभी तक
ना आपने ये दो तो टी बोला है ना वो कौन सी को ये
वो कौन से
प्रेम और गीता
नहीं गीता करवा दे यार
खाना वाना खिलवा दे इनको।
चल ठीक है
अब ये बताओ आपको ये एक तो ये हर्षा है और एक ये अनुराग है, इनमें से आपने डिसाइड नहीं किया?
अभी करेंगे ये तो जस्ट अभी आया अभी जो करेंगे ना एक तो मैंने वो बताई थी
ये रहता
लेडी
अनुसुईया बुला ली
और
फिर
एक और
उसके
बता
बाद में ये है ए, फिर ये बी 4 नंबर पे,
सरिता
हाँ ये बी है और ये है ए कुलदीप। आपने लगाया
अभी
ये
अनुसुईया होगा एक तो और एक डेमो होगा सरिता कुलदीप करा दे
करा दूं?
हाँ और वो भी करा देना उसका कौन सा था दूसरा
हर्षा है और ये अनुराग।
इसमें दो सीढ़ी कौन सी थी यार तुम क्यों कंफ्यूज
तो
करते
ये
चुप रहे
प्रेम कमल और गीता मीना।
प्रियंका और
प्रेम कमल और गीता मीना ये
प्रेम कलर का है
ये दोनों खाना खिलवा दिया,
प्रेम को तो खिलवा दे करवा दे
दोनों को खिलवा दिया।
यार मैंने अनुपम को बोला था इनको
उन्होंने बोला है कि कल करवा दो, खाना खिलवा दे इनको। उन्होंने टी लिखा है दोनों।
पागल है यार ब्रेक नहीं खाया तो करवा दे यार
मैं पूछ लेता हूँ।
ये दिखानी नहीं है ये जो है ना 192 ये थोड़े अलग अलग थोड़े करवाना है कल सुन मेरी बात अभी मैं दोबारा कंफ्यूजन इन दो को नहीं हो तो करा देना दो केस दिखाऊंगा अभी अनुसुईया और सरिता ठीक है और अब कल के लिए ना एक मिनट में एक बार कंफ्यूजन नहीं रह जाएगा एक तो क्या रखा था वो जो था ना जिसके ड्राफ्ट तो लिखा था मैंने कहा है वो ड्राफ्ट तो
ये रहा,
क्या नाम है
ये विवेक।
एक तो टुमारो कल के लिए एक शाम को आएगा अभी वो ड्राफ्ट 3 वाला ये भी जैसा है अभी होगा जयंती लाल दिखाना बूंदिया मेरे माथे है ना जयंती लाल क्या एक मिनट जिसमें होगा ये तो है मेरी हार्ड डिस्क
There have been